Welcome everyone to this Sunday evening program with Kolkata ISOPAB chapter. Let me first introduce the convener for today's program, Dr. Bishwajyoti Guha. He is a well-known consultant obstetrician and gynecologist in AMRI Hospital Mukundapur and Bhagirathi Neotia Hospital Newtown. He is currently the Joint Secretary BOGS, Council Member AICC RCOG East Zone, Honorary Secretary ISOPAR Kolkata Chapter and Clinical Examiner MRCOG Part 3. Dr. Biswajyoti, the digital stage is yours. Sir, you are currently muted.
Thank you, Session, for your very kind presentation and kind introduction. I would just this thought actually came to me while during the pandemic that we were not having any sort of a meeting, and ISOBAB Kolkata chapter has gone into hibernation. So I thought maybe just let us have a little bit of a interaction amongst ourselves. And I had and Bharat Serum vaccines were very they congenial, and they provided the platform for this program today. I thank you also, Session, for making this program in such a short time. Now, is it okay if I share my screen and start my introduction?
Please go ahead, sir.
Can you see my screen?
Sir, we are able to see your screen at this point, the desktop, sir.
Yeah, okay. So that's me. But I am now an ex-joint secretary of the Bengal Society. I was also a council member of AICC RCOG East Zone, and the elections are currently going on as we speak. The honorary secretary of ISOBAB Kolkata chapter, and I have been fortunate enough to be a clinical examiner in MRCOG Part 3. Now, I would just like to introduce to one of our very famous faces of Calcutta, Professor Arup Kumar Maji, who is currently the professor and head department of GNO, Arjikar Medical College, Kolkata. He is also the national vice president of the Indian Society of Perinatology and Reproductive Biology. He is the president of the Kolkata chapter ISOBARB. He is a past president of the Bengal Obs and Gynae Society. He is an emeritus of the Indian Journal of Perinatology and Reproductive Biology. He is a national corresponding editor of the Journal of Obstetrics and Gynecology of India. He is the officer in charge of HRRC ICMR Arjikar Medical College, Kolkata. He is the author of the Bedside Clinics in Obstetrics, and let me tell you, that's a very popular book among the undergraduates now, and author of the Bedside Clinics in Gynecology. He is a contributor of chapters of many books. He has more than 90 publications in various journals. He has also been an undergraduate and postgraduate DNB examiner and accreditor. So the dais is all yours, Professor Arup Kumar Maji, for your presidential address.
Good evening, everybody. Thank you, our dear, very dynamic Secretary, Dr. Biswajyoti Guha, for your kind introduction of myself. On behalf of Kolkata ISOPAR chapter, I welcome you all in this important CME organized by Kolkata ISOPAR chapter. And as you know, the Indian Society of Perinatology and Reproductive Biology is a national society with many chapters at present, and its head office was at now Patna, and it was originally founded in 1978, more than 40 years back, was dedicated to the well-being of the mother, child, and their family. And the founder president was Dr. Kamalari Achia, and along with them, the many stalwarts like Dr. Torun Banerjee from Kolkata, Dr. Nagen Rai Chaudhary, Dr. Rohit Bhatt, and also the Dr. Ajit Mehta, and many other persons. And subsequently, very important persons and stalwarts has come, Professor Geetangoli Mukherjee, Professor Manjugita Mishra, Professor Jagadishwari Mishra, Professor Sujit Chakraborty, and recently our president is Dr. Usha Sharma, and Meena Samant is the Secretary General. at present more than 2,500 members in our society. It's a national society, but with a big heart. The society with a big heart, and we feel like it is our family. And there are now 24 chapters. The chapter concept was born by in the mind of Professor Dr. Sudip Chakraborty, and we are very lucky Dr. Sudip Chakraborty is here in the today's meeting. And in today's CME, there are three brilliant speakers, all of you are very well-known figures. Dr. Tulika Jha, an associate professor, presently the clinical secretary of the Bengal Obstetrics Society, and he is actually the trainer of the all government programs in West Bengal government. And Dr. Sita Ramurthy, one of the famous fetal medicine specialist attached to in a big hospital, and also with us Dr. Pooja Banderkar, and the Vadya hospital is a very brilliant speaker. And the topics will be covered today is the RH and also the postpartum hemorrhage. So with these things, I request Dr. Vishwajyoti Guha for the subsequent session. Student digital platform is yours. Vishwajyoti, please.
Thank you very much, Professor Arup Majhi. I would now like to introduce one of the father figures of gynecology of Bengal. And sometimes I call him the Chanakya of Bengal, because he has been into the medical politics for so many years. And he's a very loving figure amongst us, always guiding juniors. And it's my proud privilege to introduce to you Dr. Sudip Chakraborty. He is the president of the Bengal Society from 1999 to 2000. He is the vice president of FOXY 2001 to 2002. He is the president of ISOBAP 2012 to 2014 and the chair of the East Zone RCOG representative committee from 1997 to 2003. Now, how did I come to know about Dr. Chakraborty? It was in Plymouth when I was working in Derriford Hospital in Plymouth, when in one fine summer afternoon I was invited to one of Keith Green's party in a farmhouse in the moors. And when I went there, Dr. Green, when in a very light mood, after a couple of beers that he had taken, he asked me, "You are from Kolkata, my chap. Do you know Sudip Chakraborty?" I said, "I have heard of him, but I have never met him personally." So he told me, "Oh, well, he was with me when we were training in King's College London." And Keith Green is the founder of the K2G module of CTG that we all train when we go abroad. And I was very surprised. And when I came back and I asked him, he politely said, "Yes, Keith was I used to work with him." So I hand over this session to Dr. Chakraborty, who will give a little bit of introduction of his brainchild, the ISOBAP Kolkata chapter. Thank you, Dr. Chakraborty, and the stage is all yours.
Am I on now?
Yes, sir.
Thank you. I'm very happy to be here this evening on this function that has been organized by ISOBAP Kolkata chapter. And I would give the credit to our energetic secretary, Dr. Vishwajyoti Guha. I think it is possible that the chapter will have many more activities in the coming years, mainly because we have a very dynamic leader in Professor Arup Majhi as well. I hope that after a long slumber, we will wake up and have activities to this chapter of Kolkata. I would like to mention one more thing here. I think ISOPAB as a whole needs a focus, a primary focus. Now, we are principally a perinatology society, and perinatology actually means maternal fetal medicine, which is now a subspecialty in obstetrics. Now, in majority of the developed world, obstetrics and gynecology are separate specialists. So people practice either this or that. I must say there are all-rounders who participate like we do here. And it is something like the cricket match, 11 players you have batsmen, you have bowlers, but you also have a couple of all-rounders. Now, all-rounders are necessary, but in much smaller number than what we have now. It is necessary for smaller hospitals, for smaller communities, but for a metropolitan area like Kolkata, we need separate specialists, some obstetrician and some gynecologists. And I hope that this would come forward sooner than later. Now, considering the other aspect, this is mother and child basically. And I find in the last maybe 7, 8 years, there have been lots of units of mother and child that are growing in different parts of our country as private institutions. Now, here in Kolkata also, there are 2 units which do mother and child only. And both of these units are doing well and gradually getting better. So I think the private institutions are also interested in mother and child units. Now we need specialized obstetricians who will take care of these units. And we need to do that, as I said, sooner than later. I wish this society will continue to grow and prosper, and it will attract younger talents. Thank you very much for the opportunity.
Thank you very much, sir, for your very kind introduction and giving us some time, valuable time today in the evening. Now, our first speaker and our first topic is routine anti-D prophylaxis in pregnancy. And as you know, this is one of the very important practice points in our practice, in our obstetric practice. And to tell us more about this routine anti-D prophylaxis, we have Dr. Tulika Jha, who is an associate professor of obstetrics and gynecology of RG Medical College, Kolkata. She is a member of the core committee high-level task force for maternal health, Government of West Bengal. She is a state trainer for BMOC, NSSK, PPIUCD, Lakshya, and CAC training courses. She is the clinical secretary of Bengal Obstetrics and Gynecological Society, and the current and will be the joint organizing and in fact the joint organizing secretary of AICOG 2022. She has several publications in national and international journals, and she has a special interest in vaginal surgery, high risk pregnancy, family planning, and contraception. So the virtual dais is all yours, Dr. Tulika, and please start sharing your screen. Thank you.
Thank you, Dr. Guha. Dr. Tulika, before that, I just introduced Tulika in another way, because which is not written here actually. I am heading on department of the big hospital in Kolkata where more than 70 deliveries per day. And in fact, the Tulika does every work in my department. Without Tulika, I am helpless. Not only my department also the hospital is many aspects. Tulika is inevitable. I do not know. He's actually living encyclopedia or living computer, you can say. Tulika, now digital stage is yours. Now we will hear about the RH prophylaxis. Tulika.
Thank you, sir. Thank you so much for your kind words. Thank you, Dr. Professor Maji. Thank you, Dr. Guha, and thank you, Dr. Chakravorty. Good evening, respected chairpersons. Good evening, my co-speakers, and good evening, all the audience whom I cannot see, but I know you're there very much. But just before saying, I'll just like to switch off my video because I think my internet may disturb. So I'll just switch off my video. Routine antenatal anti-D prophylaxis, RADP. This topic is really important, as the chairpersons mentioned, because this has been discussed over a long time. It has been discussed over many years, but as such in India, especially in West Bengal, there hasn't been any consensus or an affirmative decision that this has to be used, how it should be used, and all. So I think we need discussion on this topic very much, and I would thank the organizers for using this, for choosing this topic today. Now, just a few words about the pathology. Rh negative status of a mother and Rh positive status of a father could lead to the birth of or conception of an Rh positive fetus. And we all know that this could lead to RHD alloimmunization. Why are we worried about that? Because RHD alloimmunization may lead to the hemolytic disease of the fetus and newborn, and it entails hemolytic anemia, jaundice, hydrops fetalis, intrauterine fetal death, or early neonatal death. But the most important point here is RHD aluminization is the only preventable cause of HDFN. Next slide, session. Next slide. Session, next slide.
It's currently the HDFN slide, madam.
After that, the one after that. Now, what is the prevalence of Rh negative individuals in the society in our country? Is it really worth thinking for? Yes, it is not too high, but it is a considerable number. In the West, in non-Hispanic whites, it's 15%. As we go east, it reduces. And in Indians, it is about 5% of Indians have carried the Rh negative individuals. Incidence of alloimmunization in an Rh negative woman is 16% if she's carrying an Rh positive baby. Next slide. But this has reduced to 2% because of the routine postpartum anti-D immunoprophylaxis. Routine antepartum anti-D prophylaxis has reduced it further to 0.17 to 0.28% because some countries are using it routinely. And because of this, the mortality due to hemolytic disease of the fetus and newborn has reduced from 46 to 1.6 per 100,000. Next slide. So it is a well-known fact that sensitization occurs at the time of childbirth and also during sensitizing events, which we all know about. There are quite a few, to name a few: spontaneous abortion, ectopic abdominal trauma, APH, etc. And we have to remember that small amount of feto-maternal bleeding occurs in all pregnancies, even in the absence of sensitizing events. Next slide. Next slide. If we put a few figures to this, we can see that in the first trimester, 6.7% of the women will have some kind of a feto-maternal hemorrhage. This doubles in the second trimester and doubles further in the third trimester to 29%. And during delivery, as we know, it's about 76%. The volume also increases with the trimester and as the pregnancy progresses. From 0.07 ml in the first trimester, it may be as big an amount as 0.19 ml. Yes, this is big in terms of feto-maternal hemorrhage. Next slide. Because if the amount is 0.1 ml, there is 1% risk of sensitization. If it is between 0.5 to 1, it is 25% risk of sensitization. And if it is more than 5 ml, the risk of sensitization increases to 65%. So each ml, each 0.1 ml is important as far as sensitization goes. Next slide. Now we have to remember that in 2/3, it may be sufficient to provoke an antigen-antibody reaction. And prevalence of feto-maternal hemorrhage of at least 30 ml is 3 per 1,000 pregnancies. This figure is important and vital because when we give 300 micrograms of anti-D, it is good enough to neutralize 30 ml of a feto-maternal hemorrhage. But postnatal administration sometimes may be too late to prevent some cases of sensitization. Next slide. Now this brings us to the first two poll questions. Session, would you please show the poll questions? I think I would request the audience that you would see two questions, one after the other on your screens. And I would like you to give your options.
The first question, yeah, madam, if you'll read out the question.
The first question is, do you think routine antenatal anti-D prophylaxis is necessary? Options are yes or no. I would like to know the opinion of the audience. And is it still the first question on their screen? Session?
Madam, they can access both the questions.
Okay. And the second question for the audience is, do you routinely advise RAADP to pregnant women under your care? So the options again are yes or no. So after this slide or so, you can tell me the polling results. Okay, Sesh. So that brings us to the question of to prescribe routine anti-D or not. Next slide. What do the different academic bodies say? We have the organization NICE, we have ACOG, we have World Health Organization. And in their opinion, even if there is a bit of a difference, most of them say the same thing. Next slide. NICE in the technology appraisal guidance in 2002 and again in 2008, they discussed and mentioned about the clinical effectiveness and cost effectiveness of routine anti-D prophylaxis for RHD negative women in pregnancy. They also discussed about the use of routine antenatal anti-D. Next slide. And they recommended it as a treatment for all pregnant women who are RHD negative and who have not been sensitized to the RHD antigen. And they also mentioned that when a decision has been made to give RAADP, the preparation with the lowest associated cost should be used. Next slide. And the recommendation was 2 doses of anti-D immunoglobulin of, just a minute. Of
Madam, do you
2
want me
doses.
to declare the results of the poll?
After this slide. So 2 doses of anti-D immunoglobulin of 500 international units, one at 28 weeks and one at 34 weeks, or a single dose of 1500 international units, either at 28 weeks or between 28 and 30. Now, 1500 international units is basically 300 microgram of the anti-D immunoglobulin. Yeah, after begins the session, the results of the polls.
So to the question, do you advise RAADP to RH negative pregnant women under your care? 100% say yes, they do.
Very good.
To the next question, do you think routine antenatal anti-D prophylaxis is necessary? To that, the answer is also 100%. So yes.
Oh, very nice, very nice. That's very good. So my job has become easier now to convince the audience about the use of RAADP. Still, to move on with the presentation. Again, the British Committee for Safety in Hematology 2014. The guidelines are in accordance with the Green Top guidelines published in 2011. Next slide. They also mentioned that all D negative pregnant women should get a single dose at around 28 weeks or 2 doses around 28 to 34 weeks. It is the same as the NICE guidelines. Next slide. They also put a special emphasis on the point that this has to be regarded as a separate entity and administered regardless of and in addition to any anti-D that the lady may have received for a potentially sensitizing event. So that if she has some doses for sensitizing event, this will be as a separate entity and this has to be given as per the dosage schedule. Next slide. The ACOG, on the other hand, recommends single dose at 300 micrograms at 28 weeks. Next slide. The Canadian Society again has 2 options. You can go for single dose of 300 micrograms at 28 weeks or 2 doses of 120 micrograms of anti-D at 28 and 34 weeks. And the Australia and New Zealand College of Obstetricians and Gynecologists, they recommend 2 doses of 125 microgram of anti-D immunoglobulins at 28 and 34 weeks. So majority, if you see all the bodies, NICE and the British Committee for Safety in Hematology, they are okay with single or 2 doses. And so even the Canadian Society is okay with any of the 2 dosage schedule, while ACOG wants single dose of 300 microgram and the Australian College, they want 2 doses of 125 microgram at 28 and 34 weeks. So this is the present standing of all of the important academic bodies. Next slide. And here comes the third poll question. What does the audience think, whether we need 1 dose or 2 doses? So I would like session to put the poll question on the audience screen. Is it there on the audience
activated,
screen?
madam.
Okay. I'll just wait for a few seconds before you give me the answer, because the question for the audience now is if you do prescribe RAADP, how many doses of the injection do you usually prescribe? 1 or 2? Do you have the answer, Session?
I'll just show this answer as a graph so it becomes easy for you. Just one
Yeah,
second,
sure.
hold on. So just to show it very quickly, so here you can see that 75% have told one dose, whereas 25% say it's two doses.
Okay. So majority of our audience are convinced and they believe that one dose is enough. So fair enough, because all the bodies are also saying one dose is okay. So, but what does the evidence say? Moving on with the presentation. Yes, Ashna. Slide number, I think it's 23. So, next slide. Basically, there is no direct comparative data which is available or to allow an evaluation of the relative efficacy of single dose versus two dose regimen. Next slide. Though the committee of NICE guidelines, the committee decided that it could not make a firm recommendation for either the single dose or the two dose regimen. So there's still confusion. Next slide. But a study by Pilgrim et al. In 2019, they were quite clear that a single dose is more cost effective, which we all know, obviously. It potentially enables better compliance and it provides logistic benefits. But regarding the immunoprophylaxis part, one dose or two doses, the verdict is not yet clear, and so any of the two can be used. But the important thing to see is the dosage is different. If we give one dose, the dosage is much higher. We have to remember that. And if it is two doses, then the dose differs. The dose becomes a bit lower. It is not the same dose for one dose regimen or the second or two dose regimen. Next slide. Now, multiple doses, not for prophylaxis. I just wanted to mention this here, that multiple doses may be needed in women, especially after a sensitizing event. Why? Because we need to remember that 300 microgram dose covers a feto-maternal bleed of 30 ml, which occurs in about 3 out of 1,000 pregnancies. But a bigger bleed will need multiple doses. So how will we know how much is the bleed? We have to identify feto-maternal hemorrhage, and then once identified, it needs to be quantified. How do we identify? First of all, there will be a history about some of the sensitizing events which we all know about. And I think my next speaker, my friend Sita, will be elaborating on that maybe. And also if there is a history of antepartum hemorrhage in an Rh negative woman, if the patient complains of decrease in fetal movement, if there are changes on the cardiotocograph and there is an increase in the mean middle cerebral, the MCV, PCV in the middle cerebral artery. So this will be on USG. So if there are such findings, then we need to go for a quantification of the feto-maternal hemorrhage. Next slide. And identification can be confirmed by a qualitative test, which is the Rosette test, which identifies basically the presence of fetal cells in the maternal blood. Next slide. And Kleihorn-Betke test, which is a very well-known test. It is one of the quantitative tests, and it is a bit painstaking because you have to count how many fetal cells you can see and how many maternal cells. The slide sometimes looks like this, like in the picture I've shown here. And you really count the number of fetal cells in a particular field, and the maternal host cells also you need to count, and then there is a formula. Next slide. Flow cytometry, on the other hand, is more sensitive and accurate and less painstaking, and it is automated also, which basically identifies the hemoglobin, which is the F hemoglobin, whether there is the adult hemoglobin and the percentages of that, and by that they can give a amount of the feto-maternal hemorrhage. Next slide. And this is the formula by which you calculate. So once you know the feto-maternal hemorrhage, then depending on that amount, we may have to give multiple doses of anti-D during pregnancy. Next. Now, after seeing all the body's recommendation, I would like to discuss a bit of the WHO recommendation, which was published in 2018, because it is a bit on the other side of what we have discussed so far. Next slide. The question which WHO raises is routine prophylactic anti-D administration compared with no anti-D effective for preventing rhesus, alloimmunization, and improving outcomes, which is a question for all of us. Next slide. The evidence which they went through was basically from the Cochrane review, and in which two RCTs were analyzed, a cohort of 4,500 Rh negative women, mostly primary gravidas. Both the RCTs compared single dose antenatal anti-D with no prophylaxis. One trial used 500 international units, and the other trial used 250 international units, both between 28 to 34 weeks. 8 to 34 weeks. Next slide. Now, the data was available for 3,900 pregnancies, out of which 2,000, almost 2,300 newborns were Rh positive. The primary outcome which was analyzed was isoimmunization, which I will discuss in the next slide. But there was no clear difference in the risk of fetal and neonatal outcome, including jaundice, in these trials, in both these RCTs. Next slide. When isoimmunization was quantified by KB test, it was seen that women who receive RAADP are less likely to have positive Kleiner-Betke test during pregnancy, and also at birth of an Rh positive infant. So that is one positive thing which was, which was in favor of RAADP when these two trials were analyzed. The rates of alloimmunization were also lesser than in women who did not receive the anti-D, and that was 0.6% during pregnancy, 1.1% at birth, and 1.5% at 12 months postpartum. Next slide. But another point which WHO made was 40% of these women had D negative children. So basically, 40% of the women unnecessarily received the antenatal anti-D injections. Next slide. So poll question 4, but I think this question is not important anymore, because the question was that if you do not prescribe routine antenatal anti-D, what is the reason behind it? But in our poll, I can see everybody prescribes. So I think the question is redundant. I no need to go for this poll question session. I'll move on with my slides. Okay.
Madam, just to intimate that although everyone has said yes, the answer that people have given is 50% say that cost is one of the reason, and the other 50% say availability is an issue.
Okay. So two important. My question was, why don't you prescribe if you don't? Is cost an issue? Is availability is an issue? Are you not convinced about the utility? So I think 50% are divided between, the house is divided between cost and availability. Everybody is, it seems, convinced about its utility, which is good in a way. So next, and WHO also discussed about 4 important points: resources, equity, acceptability, and feasibility. Yes, cost, as our audience mentioned, resources is one important point. I think the cost in US is about $100 for 2 doses, or 1 dose is $50 or so. In India also, the cost, even if it has come down from what it used to be, it hovers around 2,000 rupees still. So it may not be very easy for people to afford that, especially in the peripheral areas, in the rural areas. And again, availability is also a problem there. It may not always be available for for use. It may take a few days to procure it from the urban areas or from the city. So resource is one problem. Equity also, because everybody may not be able to, if a country gives a guideline, everyone should get that anti-D injections. But in a diverse country like India, that may not be possible. Acceptability in some countries, especially in the African countries, in other countries as well, in some, in some Jews, in some other classes, I would say that many people do not accept the anti-D injections which are prepared from the human plasma. But I know there are also ion chromatography based preparations now, but it may not be acceptable to all people. Feasibility, because anti-D has to be, preserved at 2 to 8 degrees centigrade. The cold chain must be okay. So all these points may not be well maintained. And so WHO was worried about these 4 points. Next slide. And so the questions, it raised a few questions, whether the prevalence is so much so as to, help pregnant women in the low and middle income countries. Is it a cost effective strategy in the low and middle income country settings, and whether it improves equity or not? These were the questions which WHO raised. And finally, next slide, please. The recommendation which it gave was a bit different from the other bodies, which is antenatal prophylaxis with anti-D immunoglobulin in non-sensitized Rh negative pregnant women at 28 and 34 weeks of gestation to prevent alloimmunization is recommended only in the context of rigorous research, particularly for low and middle income country settings. So this is what WHO has to say. Next slide. But coming to the end of my presentation, my take home message would be where affordability, acceptability, availability, and resources are not important issues or are not problematic issues, it's best to offer a single dose of 300 micrograms of anti-D immunoglobulin at 28 to 30 weeks to non-sensitized Rh negative women. Next slide. Thank you. Thank you, everybody, for your patient hearing.
You, Dr. Tulika, for your very excellent presentation. I think, Seshan, are there any questions? Because Ram, I have got two questions for her.
Yes, sir. There are 3 questions actually. I'll just post them in the chat.
Yes.
We can take questions at the end, maybe.
No, I'll just ask you.
Okay.
Important, because this has been asked by one of the professors.
Okay.
That what would you prefer? Would you prefer a monoclonal or a polyclonal Rh antibody? That's number one. And number two, is there any contraindication for an antenatal prophylaxis of RhD immunoglobulin?
Just a moment. We should have the question once again. One is monoclonal or polyclonal.
Polyclonal,
right?
which is your choice and why? And number two is there any contraindications for routine anti-D prophylaxis, antenatal prophylaxis?
Okay. Well, the answer, I would prefer monoclonal because the chances, the negative points of anti-D prophylaxis is one is it may carry infections, it may carry vaccine, viral infections. So my answer would be that it's best to go for monoclonal. But the problem is monoclonal are costlier. And I think monoclonal is available now. It's easier. It's not so costly anymore. So my answer to the Ram would be I would prefer monoclonal preparations. And the next question was?
Routine anti-D prophylaxis, where is it contraindicated?
If there is any contraindication.
Oh, the contraindication is one. First, if I already know the patient is sensitized, I don't need to, because before giving this, I need to do an indirect Coombs test also. I need to know whether the patient is sensitized or not. Second is if there is any history of any hypersensitivity reactions, and then I will not give then in those cases, I will not prescribe anti-D immunoglobulins.
Okay. Thank you very much, Tulika. We will take some more questions at the end of this session if there is any more time, but because we are actually running short of time, let me ask our next speaker,
Thank you.
Dr. Sita Ramamurthy Pal, and I'll just go over to the to my screen. Can I share my screen, please?
Yeah.
Seshan, can you please share my screen?
They are already sharing your screen, sir.
Okay, that's fine. So,
Sir, I believe you have chosen the notepad at this point. May I request you to kindly stop sharing and reshare again.
Share screen, huh? So our next speaker is Dr. Sita Ramamurthy Pal, who is also one of our very known faces in obstetrics and gynae circles in Kolkata, and to be very honest with you, one of our very close friends. She is a consultant in fetal medicine and obstetrics of Apollo Gleneagles Hospital, Kolkata. She is MBBS DGO MD from Mumbai, and She is FICOG and FRCOG. She is RCOG RCR Diploma in Advanced Obstetric Ultrasound, and she is a managing committee member of the Bengal Obstetrics and Gynecological Society 2019 to 20. Chairperson Fetal Medicine and Imaging Committee BOGS. She is an East Zone coordinator of the Imaging Science Committee FOXI. She is a member of the RCOG Eastern Zone Representative Committee, Honorary Treasurer Society of Fetal Medicine Kolkata Chapter. She is the Clinical Secretary of ISOBARB Kolkata Chapter. She is a faculty of MRCOG Part 2 and Part 3 courses, and author of 16 peer-reviewed papers and book chapters. So, and the topic today is RH ICU immunization practice points. So, I'll just share my, I'll ask her to share the screen and take on the virtual platform. Dr. Sita Ramamurthy Pal, for you.
Thank you, Dr. Guha, for that kind introduction. And I'll share my screen without. Yeah. Okay. Can you see me and can you see the...
Yes.
Thank you. So we're going to talk about RH ISO immunization, and after hearing that antenatal prophylaxis is necessary and is important, we need to know, despite all that, what is happening and what we need to detect, what we need to do to detect our fetuses who are still dying with RH ISO immunization. So when we talk about alloimmunization or isoimmunization, it is basically an immune response in an individual of one species to an antigen from a different individual of the same species. So it is the same thing as isoimmunization, and most importantly, when we talk about RH isoimmunization, it is the immune response in the mother by the RH antigen from her fetus that we all know. Now, this basic RH group antigen, the 6 genes are responsible, which are located in the short arm of the chromosome 1. And if you look at the level of immunogenicity, the most immunogenic is D, followed by small c, capital E, E, C, G. There are other antibodies as well, but the most immunogenic in the descending order would be this. And this RH antigen actually can be seen as early as 38 days after conception. So it appears very early in pregnancy, and the incidence is about 8 to 10%, which is more in the Parsi community and the Kutchi community. Now, though the incidence of the immunization prevalence described over the years in different countries, especially in our country as well, described by Suresh and Varghese, they've said 1.1. The incidence is much more, especially when you have referral centers and big hospitals where these patients come when they have not been immunized. So the first poll question, Session, if you would like to share, please answer that question and let me know what is the answer. This is also a revision as to what you heard from the previous lecture, whether you've paid any attention. So what is the minimum critical sensitizing volume for isoimmunization? Your options are A, B, C, and D. You can and let me know what the answers are. Hello?
Madam, do you want me to share and show the results? Or
yeah, please. Yeah.
I'll just share the slides. Yes, ma'am.
Right. Oh, great. Okay. So they've said that 100% is 0.5 ml and 0% is 0.1. 1 is, okay. So they've all said 0.5 ml. Right. Okay. Thank you. Going back to my, I'll share my screen again. Can you see the, yeah? Okay. So the answer is actually 0.1 ml, and Tulika has also said that the minimum value needed, minimum critical sensitizing value is as small as 0.1 ml. And if we go to revise as what happens is, if there's an RH incompatible couple where the RH negative woman and RH positive man conceive a child, they have an RH incompatible pregnancy when the baby is RH positive. And then there's a primary sensitizing pregnancy where the cells from the baby enter the woman's circulation. So that is a primary sensitizing pregnancy. Then she becomes sensitized with these antibodies to fight the RH positive blood cells. And then when she has the next RH positive pregnancy, here basically this is the IgM, it's the immune response that is there is very very weak, so it doesn't cross into the placenta. But in the second time, the IgG antibodies, it's a much more robust response. In the next Rh positive pregnancy, these antibodies attacks the red blood cells, and we find the hemolytic disease of newborn. So if the father's status is not known, there is almost a 68% chance of the baby being Rh positive. And the feto-maternal hemorrhage, as we've heard from Tulika, can be anything from 0.1 to 30 ml, and the minimum critical volume needed is 0.1 ml. So even that small amount of volume can, sensitize the woman and affect her future pregnancies. And most of this occur during delivery. And this causes the hemolytic disease of newborn, and that worsens with every pregnancy, and it presents earlier in the pregnancy. So you'll have typically women having multiple losses initially in the first trimester, then they have the second late trimesters and IUDs, and then they have died after. The other way, they would start with an IUD or post neonatal death, and then start at 36 weeks or 28 weeks. As the pregnancy, after every pregnancy, the condition worsens and they're present early. Now we know that intrauterine transfusion for fetal anemia has been the most effective and rewarding therapeutic procedure in fetal medicine. And overall, the incidence of severe HDN has decreased to less than 10%, but the incidence is still increasing. And why? As we've seen, despite recommendations of anti-D prophylaxis and despite the IUT treatments available, not everywhere though, but it is available, there is still a high rate of alloimmunization, especially anti-D, because management is still a challenge. People don't know exactly what needs to be done, when to refer. Sometimes the referral could be late because of logistic reasons, lack of awareness and uniform and universal anti-D immunoprophylaxis that we have heard, D-antigen typing errors, that something we will talk about, inaccessibility to prophylaxis, as we've heard, the cost-effective problems can be there, and insufficient dose of anti-D immunoglobulin as well, because we know that a larger fetal-maternal bleeds will need more prophylaxis, and that may be sometimes not covered. So despite receiving the anti-D in her previous pregnancy, she might still have the problem in the next pregnancy. So the aim of antenatal management, whenever you have this Rh negative woman, is to know the maternal immune status. If she's not immune, you prevent isoimmunization, because that is almost, it's a very good effective prevention. But if she's already immunized, our aim is to detect this problem early, and so that we can prevent complications and give her a healthy pregnancy and fetus. So the next poll question, can you just put it up, session, for our viewers? So the question is, when do you advise indirect Coombs test? A lady comes to you with Rh negative, you advise it at booking and at 28 weeks, at 28 weeks, or at 20 weeks. When do you advise the indirect Coombs test? So we have 50% saying at booking, 50% at booking at 28 weeks, and the rest is 0-0. Okay, thank you. Do I share it again? Yeah. Yeah. So actually, it should be at booking and at 28 weeks. So that would be the right answer. But at booking, if you find something and you need to do anything about it, there may not be. But the ideal answer would be at booking and 20 weeks. I'm happy that at least 50% have answered that. So let's come to the scenario where the mother is Rh negative. So what automatically you would do is to do a husband's blood group. And most of the time you would say that if the husband is also rhesus negative, we can forget about this this pregnancy and need not worry about it. But the problem here is we cannot had 50% of the couple of the father would be heterozygous, and that's why the baby can still be Rh positive, and that's why we need to do the antibody determination by ICT with the titer at booking and at 28 weeks. And why at booking? Because even if the father is rhesus negative, as I said, because he being heterozygous, there could be other rare antibodies as well, which we will come in the later slides, which can cause alloimmunization and other previous non-pregnant sensitizing events. Like in our case, recently we've had a lady who had a platelet transfusion because of dengue fever in some time not pregnant, and then she later presented in pregnancy. She was immunized because of the platelet antibodies, and that itself can cause problems. So you have to look at other things rather than apart from non-pregnant events which can cause sensitization. But so if the woman is ICT negative, then obviously we would routinely follow her up, and then you would give her antepartum prophylaxis. But again, there is doubt whether you would give her single or double. Now, important to remember that if she's received an anti-D, the ICT would be positive. ICT would be slightly positive, but usually it would be less than 1 in 4. And so that's why you don't need to worry about the sensitization. So ideally, you should not be doing an ICT after anti-D. And women who are already sensitized, please don't give an anti-D. As we've heard that. But postnatal prophylaxis would be the best, and it ideally depends on the Klaha, Betke, and flow cytometry. So even if the anti-D prophylaxis has been given, we need to obviously check for the baby's blood group postnatally, do a direct Coombs test, and then decide if the mother needs, because this would still be the best prophylaxis, as we've seen that 50% of this sensitization events occur after delivery, and even if the dose is sort of less in the antepartum period, we can cover it postnatally and prevent alloimmunization in the next pregnancy. Now, ideally, what would be the best is that if we know the baby's blood group, that would solve all our problems. Because if we know the baby's blood group, if the baby is rhesus negative, then we don't have to do all this monitoring and all these tests without knowing when to refer, what to do. But what are the options we have when we do baby's blood group? We can either do a chordocentesis, which is usually not recommended. Only when we do an IUT, we do a chordocentesis. Amniocentesis just for baby's blood group is not really advisable. But we do have something in our armamentarium, that the cell-free DNA, which we use so routinely for our aneuploidy screening, it can actually detect the RH status of the baby. It is very promising, but unfortunately, it's still not available with, at least the companies are not promoting this aspect of it. And I think once that comes up, that will be a very good option for us, because that will prevent a lot of cost factors and the monitoring issues that will go on with the pregnancy. So what we do, we assume the baby is RH positive and manage accordingly. So if the ICT is positive, you have to remember that antibodies can be produced against other foreign antigens, that is what makes the ICT positive, and we assume that most likely that the antigen has caused the sensitizing event. But again, I'm mentioning that the sensitizing event may be a non-pregnant event, like a blood transfusion earlier, or a platelet transfusion, which is quite high nowadays because of the increased incidence of dengue. And again, as I said, most likely RH antigen, but other antigens also can cause ICT positive. So once the ICT is positive, we need to detect the antibody, and ideally, if you can, do a quantification of this antibody that will also tell us how significantly the baby is going to be affected. Now, if you look at this chart or this table, which shows that the number of antibodies that can cause sensitization, but the first 5, like O, D, C, KEL, in fact, KEL is called KEL kills, because KEL can cause severe antibody reactions, severe hemolytic disease of the newborn. But the other ones, they can be found, but they are not so significant in the neonates. So you might have all these antibodies, but they don't cause so much significant problems in the neonate. So these are the main ones that cause, but they can be there. And because we don't see them so often, we don't usually routinely test for them. But you might have the odd baby having this pregnancy, having this problem. And that's why important to do the ICT test and quantify the antibody. Now, about the antibody titers, we know that we do it by an agglutination method, and we have our ratios as the critical titers as to 1:4, as to 1:16. But what is this figure? It is basically the highest dilution at which the antibodies are still detectable. So logically, what higher the denominator, greater the antibody load. So in this factor, I would go on to the next poll question. Session, can you put it up? So what do you think is the critical antibody titer? Is it 1:4, 1:16, or it depends on the lab, or 1:32? Session, you're putting it on? Yeah, so 66% have said 1:16. You're not, okay, thank you. And the rest are 33, 1:4, and 0 for the rest. Okay. Yeah, so the actual correct answer is depends on the lab, though 1:16 is not completely wrong, because that is what we take it for the figure, but it actually depends on your lab what gives you the critical antibody titer, depending on which antibody titer they have had the maximum number of cases of hemolysis. So if you find the lady with an Rh negative mother with ICT positive, you have a critical titer, that is value below which no cases of fetal hemolysis has been reported. And that value was usually determined by the lab. So the lab is going to give you a figure what their value is, and that can vary. But most of the times we take it as 1 in 16. Now, to complicate matters, actually, there are two ways of doing this titer. There is a tube method and there's a gel method. And what we know that whatever titers have been established, they have been established for the tube method. But most of the labs that they do, if you ask them, actually, they do it by the gel method, gel agglutination method. And in fact, the gel method of detecting antibody is actually more sensitive, reproducible, and stable. And there's another point here that though we say 1 in 16 is a critical titer, there is actually a very poor correlation between titers and fetal affection. Sometimes even with 1 in 4 titers, people have seen babies being affected, and sometimes 1 in 32 titers, the baby is quite normal and nothing happens to them. So we shouldn't be ideally going by the critical titer. But even then that would be a point of referral system. But you must remember that there is poor correlation between fetal titers and fetal affection. And this was a study done by Dr. Vivek Krishnan in 2020. Then they found that the significant titers the titers, if you do it by the gel method, are significantly higher. And 27% of the samples that were ICG positive by gel were negative by tube. So in that means that if you get a positive test by the gel method and you think this baby is at risk, if you actually test by the tube, it is going to be not at risk. But is that possible? Is that clinically feasible? That is a big question to answer, because we still go by what our lab says. Well, again, if you do antibody quantification, we can say that if it's available, you can say that if it's less than 4 international units, it's low risk. But if it's more than 15, this baby has a very high chance of developing hemolytic disease of newborn. Or if there is an increase in 50% from the previous level, that would also increase the risk of the baby being affected. So what do we have? What options do we have? If the option 1 is if the titers are below the critical level, you repeat the antibody titers after 4 weeks. If low, or 2 weeks if it's rising or near critical level. So you keep monitoring the values until it reaches the critical level, or you think it's reaching the critical level. And at that point, you would refer the pregnant mother to a fetal medicine unit for ultrasound monitoring. And once she goes there, she has to be screened with MCA Dopplers every 2 weeks. The other option is to do a direct ultrasound monitoring, because as I said, the titers may not correlate with the fetal affection. But again, there are pros and cons of this, whether you monitor them, whether you're going to miss the level and send them late, or rather if you're going to directly monitor her, the cost of the lady coming every time, logistic issues of scanning every 2 weeks and then working about it, whether you have some centers around you. So there are pros and cons of sending the patient for direct USG monitoring, and there are cons also of repeating the antibody titers, because you might miss the event occurring early. What happens if the mother has a previous affected pregnancy? Of course, then it becomes very easy, because you know that this lady is at high risk, and we know that the thing worsens in every pregnancy. So you directly ask her for monitoring, and you start the monitoring 10 weeks before the last mishap, or at least after 18 weeks, weekly follow-up with ultrasound monitoring. There has been no debate about this, and ideally all these patients who've had a previous affected pregnancy should have their pregnancies monitored in a dedicated fetal medicine center. So MCA Dopplers are the non-invasive method of predicting this fetal anemia, because for ultrasound monitoring, because gone are the days where you used to do an amniocentesis and use release charts, multiple amniocentesis, and then decide about fetal transfusion. So with the prediction of the peak systolic velocity of the MCA Dopplers, which is a very good indicator of the fetal anemic status of the fetus. So MCA was first described because it is reproducible, and the peak systolic, why do we look at the peak systolic velocity and not the PI? Because here we are looking at the blood, which is where there is hemolysis, there is less viscosity and causing hyperdynamic circulation, and that is reflected in the peak systolic velocity. And because it changes with gestational age, as with other biochemical other markers, the values have to be converted to the multiples of median and then acted upon. You have different calculators in the softwares which can calculate automatically, and any level of more than 1.5 multiples of median means that the baby is going to be severely anemic, and then you would start acting on it. Or as a rule of thumb, you can say if the mean systolic velocity is twice or more than twice the more than or equal to twice the gestational age, this baby can have moderate to severe anemia. Another important thing to look at is you have to look at the trend of the MCA PSV rather than the absolute value. So if you're monitoring as well, you have to look whether the PSV values are increasing rather than one particular value. And in fact, the recent meta-analysis said that the sensitivity and specificity of the MCA PSV is almost in the range of 86% and 71%. So this is the standard of care for all women who have been monitoring for fetal anemia. So when do we use this? In a previous affected pregnancy, you start at about 16 weeks, around 20 weeks if there is no previous affected pregnancy, and then you monitor them 1 to 2 weekly depending upon the severity and depending on what your MCA Doppler's PSV values show. What else can you see on ultrasound? Of course, if you wait for these changes of anemia, they're actually very late, and by then it might be already you've missed the boat, but nevertheless we can still try. But so what are the late changes that you can see on ultrasound? That would be placentomegaly, hydramnios, signs of impending ascites, and obviously fetal hydrops. And once hydrop sets in, it's not a lost game. There is a 40% survival, of course. The survival rate decreases, but if you act early before the hydrop set in, the survival is almost 85 to 90%. And we've had excellent figures from our country, from Mediscan, from Dr. Suresh, and from the AIMS Hospital, Delhi, where people are going home with normal, healthy fetuses. So this is a sort of a chart where we look as an algorithm where the MCA PSV, if it's less than 1.5 mom, you're monitoring, you can safely deliver at 37 to 38 weeks. But if it's more than 1.5 mom, if it's more than 35 weeks, you deliver. But if it's less than 35 weeks, you need to go in for an intrauterine transfusion. So what is the poll question for? Session can just put the last one. That is IUT contraindicated in the presence of hydrops? Yes or no? If the baby has already developed hydrops, would you go ahead with IUT or no? Yes, 50%, no, 50%. Okay, that's interesting. Thank you. Well, you can go ahead with hydrops, and it is, as I said earlier in my slide, though the survival rate decreases, it's not actually contraindicated. There is still hope for the baby. So what would be the indications for IUT where the MCA PSV is more than 1.5 mom? There is signs of fetal anemia, even though it might be hydrops, you can still go ahead, but you must counsel the patients, the couple accordingly, or if there's an increase in ICT titers of more than 4-fold. So in a brief note about IUT, that intrauterine transfusion is usually done intravenous, umbilical vein, or the intrahepatic vein at the site of the placental insertion, and not the free loop because it's quite difficult. Or sometimes you can do an intraperitoneal transfusion as well. And what sort of blood we use? We use an O-negative cross-matched blood with the mother. You do obviously screen for infections like HIV, HPSAG, hepatitis C. Has to be CMV seronegative and leukodepleted so that there is no graft versus host reaction. Packed cells ideally so that the volume of load that you're transfusing is less. Has to be fresh within 7 days and irradiated blood again to prevent graft versus host reaction. Volume to be transfused depends upon the initial fetal hematocrit and the donor hematocrit. It is usually a software-based calculation. Again, you can do it, but there are other methods. I'm not going into details like the transfusion coefficient. And for every 1 gram rise, as a rule of thumb again, you have to transfuse about 10 ml of packed red cells. And the target is to reach 45 to 50% of the fetal hematocrit. And every time you do an IUT, you do a pre-transfusion hematocrit, and then you do a post-transfusion hematocrit to decide when the next transfusion would be, and then accordingly take it from there. Because once you transfuse, you cannot completely rely on the MCA PSV. Again, very important, before you transfuse, you must check the baby's blood group, because obviously when you're transfusing O-negative blood group, the baby's blood group will change after that. The procedure is obviously done in an OT, ideally, so that if there is an element of emergency, we go in for an immediate cesarean section. Fetal paralysis, you check the fetal blood group, as I said, and obviously we need skilled trained personnel to do this. Further care depends upon how early you have started the transfusion. So it depends, and the mother might require the fetus might require repeated transfusions. But usually the last transfusion is done around 34 weeks. So that delivery is usually done after 3 weeks of the last transfusion. But any time after 26 to 28 weeks, you must prime the baby with steroids. If the transfusions go on fine, you can deliver at term, and cesarean section only for obstetric causes. And of course, a baby will may need exchange transfusion depending upon what the complications are. What about the newer treatments? We do have IV immunoglobulin, but it's reserved for women with homozygous husband and a prior hydropic fetal death before 22 weeks. So ladies who have multiple mishaps earlier and then they present early, this has been tried with success. In fact, along with the transfusion, they give IV immunoglobulin, and it reduces the severity of the disease by decreasing the antibody production. So my practice points for the RH-ISO immunization is to do an ICT at booking and at 28 weeks. I think we have to focus on the postpartum prophylaxis to prevent this deadly condition, which is so preventable, because antenatal prophylaxis still is not up to the mark. ICT positive will depend upon the critical titer for your lab, but don't go completely by your critical titer, because that can vary with the infection can vary. It can be irrespective of the critical titer. Any titers above critical value, please refer to fetal medicine specialist wherever you can, so that the baby has the best chance. Monitor for fetal hemolysis and anemia by early identification of anemia and prompt management by IUT. And if NIPT can be used for this purpose, I think that would be a great help and reduce the load of monitoring these babies who might not actually need that much of monitoring. Thank you so much for your patient hearing.
Thank you very much, Dr. Sita, for your excellent presentation. And are there any questions, Session? Are there any questions, or can we move on?
No questions posted as of now, sir. Maybe they will come in.
Okay, so that's maybe at the end of the session we'll take some questions, Dr. Sita.
Okay,
so please be with us, stay with us for a little while. And can I share my screen now? Yes, thank you. So thank you very much, Dr. Sita, and we will move on to the next part of our program, which is Dr. Pooja Bandekar. And she is actually a guest speaker today, and she is an MD, DNB, FCPS, DGO, DFP. She is an associate professor at GS Medical College, Mumbai, and the head of the unit Wadia Maternity Hospital of Mumbai. And she has got some other aspects through her academics. You know, she is also the winner of the regional Saregama Z TV 2000. She is a winner close-up of Antakshari Z TV 2000. Winner of Rambandhu Antakshari Shayadri 2008 and Mumbai Mayor's Award 2012 for parallel proficiency in music and medicine. So she has got both the aims together with her. And Dr. Pooja Bandekar is going to enlighten us on PPH practice points. Dr. Bandekar, the stage is all yours.
Yeah, thank you so much, sir. Good evening, Kolkata, and good evening, Bharat. I bring lots of greetings from the city of Mumbai, and I am here to give you an overview of PPH along with practice points, which I will label as Pooja's Tadka. So, moving on to the next slide. Friends, the moment a child is born, the mother is also born. She never existed before. The woman existed, but the mother never. The mother is something absolutely new. Coming on to what is PPH. Next slide, please. Friends, postpartum hemorrhage remains a major cause of maternal mortality and morbidity worldwide. Approximately 500,000 women die annually from causes related to pregnancy and childbirth. I know I'm speaking in front of an august audience and everybody knows everything about PPH. But there is one thing which neither me nor any one of you know, and that is when and in whom is that PPH gonna happen. And that is the beauty, a beauty which is not required, but beauty that PPH has. Friends, our best estimate is nothing but a gross underestimate. 2 lakh women die from PPH each other. Mind you, 25% of the maternal mortality is due to PPH. All I can say is 100 साल पहले PPH था, PPH है और PPH रहेगा, तो हम उसे भूलने की गलती नहीं कर सकते. Moving on to my next slide. The beauty is all pregnancies are at risk of PPH, whether there are predisposing factors or there are no predisposing factors. What is PPH? It is any bleeding from or into the genital tract following the birth of the baby right up to the end of puerperium, which is 42 days post-delivery or 6 weeks. Next slide. And this is the genital tract and the various organs involved. Next slide. Incidence. As I said, in the developing countries, several countries have maternal mortality rates in excess of 1,000 women per 1 lakh live births. WHO statistics suggest 25% of maternal deaths are due to PPH, accounting for more than 1 lakh maternal deaths per year across the globe. And that figure is quite alarming and quite a bit. Next slide. There are 2 types of PPH. The primary PPH is anything happening within 24 hours of delivery, and the secondary PPH is something happening between 24 hours of delivery and the next 6 weeks of delivery. Next slide. Now we just brush upon the causes of postpartum hemorrhage. I mean, I'm definitely going to come to that mnemonic of the 4 T's, but this is a list of the causes of primary PPH: atonic uterus or trauma or a mixed picture or a retained POC or a uterine rupture, inversion or a coagulopathy. And the next slide are the causes of secondary PPH: retained bits of placenta or products of conception, any infection, endometritis, a trauma to the genital tract, a cervicovaginal laceration, subinvolution, secondary hemorrhage resulting from a C-section, and other rare causes. I know one may think that why are these rare causes so important? Why rare causes always are important in life is they could be the rarest of causes. It could just be, 0.1%. But for the lady who has a PPH due to a chorion epithelioma or a carcinoma cervix or placental polyp, it is a 100% loss for that particular lady. Hence, the rare causes also are extremely important. Next slide, please. And these are the risk factors. I remember saying that any and every woman is predisposed to PPH, but nevertheless, it is very important for each one of us to know where should I be much more prepared for a PPH than any other delivery. I will repeat again at this point of time that there may be a risk factor or there may not be a risk factor, but whenever you have a lady in labor, the one thing which has to be at the back of your mind always is PPH. So this is the list of risk factors: prolonged third stage, multifetal gestation, which is delivering, an extended episiotomy, a big baby, history of postpartum hemorrhage in the past, a gland multipara, placenta previa or placental abruption. So something which can cause antepartum hemorrhage can definitely go on to cause postpartum hemorrhage, pregnancy-induced hypertension and infection. Next slide. And what are the symptoms? There is blood loss, and there is blood loss. And due to which there is pallor, there is fatigue, there is anemia setting in, there is hypovolemia, there is hypotension, there is tachycardia, there is a low volume pulse, there is a thready pulse. And if it is a traumatic PPH, then there could be swelling, extreme pain, cyanosis, dusky look due to underlying hematomas in the vaginal and perineal area. Next slide. And now, this is something which I think we have been taught right from our first MBBS, are the 4 T's which bring to us the etiology of PPH. Tone, which attributes to 70% of the cause; trauma, which attributes to the 20% of the cause; tissue, which attributes to 10% of the cause. Now, you may feel that something has gone wrong with the maths of Dr. Pooja, because 70 plus 20 is 90 and 90 plus 10 is 100. Then why is that thrombin 1%? That is because thrombin can be a subset of the upper 3 T's. Next slide, please. So that's the diagram. Next slide. It's a crying uterus. Yeah, so these are the various reasons. I'm not going to every reason because it's such an august audience. I'm sure everybody knows the 4Ts, the subsets of the 4Ts. Next slide, Mr. Session. Yeah, so these are the FIGO recommendations for prevention and treatment of PPH. I think the basis, the foundation stone for PPH is active management of third stage of labor. So judicious use of uterotonics, controlled cord traction only under vigilance or under supervision, or if recommended otherwise, it is spontaneous expulsion of placenta and uterine massage after the delivery of placenta. Now suppose PPH sets in, that is if it's a vaginal delivery with a blood loss of more than 500 ml, or a cesarean delivery with a blood loss of more than 1 liter, or if it's a hysterectomy, an obstetric hysterectomy with a blood loss of more than 1.5 liters, or there could be any volume of blood loss, but if the woman is vitally unstable, then what are we going to do? If there is ongoing bleeding, you have to maintain the airway, breathing, and circulation. You have to keep on replacing whatever she's losing, assess, find out the cause, and treat it. Next slide. Now, we all know that prevention is better than cure. I wanted my previous slide. Yeah. So prevention of PPH has to set in right from the antenatal period. In fact, I would like to say that, I am into practice now for almost 16 to 18 years. And these days I have started getting couples who come to me and say, ma'am, we are planning a pregnancy. And can you tell us what is to be done before I go in to take a chance of pregnancy? So prevention of PPH, in fact, can start from even antenatal, even before antenatal period. Like if the couple comes to you for counseling, you can definitely assess the lady, and along with the other things, an important component of the battery of test would be a CBC. Similarly, if the lady comes to you first time in the antenatal clinic, then you have to look at these points in the antenatal visit. Improvement of the health status of the lady. Remember one thing, when I am saying of health status, it is not just physical health. I know every one of us is looking at physical health, but coming down to the 21st, moving now towards the 21st century, and at the end of 2020, and from whatever the pandemic has taught even me in this year, I have realized that mental and emotional health is equally important along with physical health. It definitely was always important for me, but this pandemic has really enforced and reinforced the importance of mental and emotional health to me. So when the woman comes to you in the antenatal clinic, she may be saying something to you on the face of it, but there must be something between the lines. In case you feel that there is some other underlying factor which is affecting our health, try to point out that factor and treat it. But of course, other important things are screening for the high-risk patients and a blood grouping on the lady, so that last minute you are not caught unawares with something extremely rare like a Bombay blood group. All right. Then you go on to the intranatal, slow delivery of the baby. There is no rush in delivery of the baby. Nature has its own way of expelling the baby. And I personally feel we as obstetricians, along with nature, bring about this beautiful process of childbirth. An obstetric anesthetist, be ready if we are dealing with labor analgesia, if you are planning to give labor analgesia. And as I always told you, I know we can use controlled cord traction, but only if indicated. Otherwise, my policy, even during a cesarean section, is to await spontaneous separation and expulsion of placenta and membranes. Next slide. Okay. Active management of third stage of labor, as I told you, is about appropriate use of uterotonics. Yeah. Then we go on to examination of the placenta. I feel that placenta is like an encyclopedia. It is a tissue. If you look at the microscopy, also it is like a textbook. It has a lot to tell you. If you look at the gross appearance, also it has a lot to tell you. So even looking at the placenta, you can understand whether this lady had some amount of APH, whether there was any underlying cause for causing APH or PPH. Is the placenta complete? Has the membrane come out in toto? Is anything left inside? Is there a cord abnormality? Have we left a bit of the cotyledon inside, etc., etc., and so on and so forth. Then once everything is over, you examine. There is nothing that can beat a good and thorough clinical examination. Okay, so a proper examination and evaluation of the perineum, of the vulva, of the vagina, of the cervix in good setup, good exposure and good light will help us understand whether is there any bleeding. If yes, what is the color of the bleeding? Is it an altered blood which is coming out, which is nothing but a collection? Is it a bright blood? Is there a gush? Is there a trickle? And is there a mixed picture? Is it only atonic? Is it only traumatic? Is it atonic with traumatic? And after all this, you have to observe the patient for about 2 hours post delivery. And remember, out of these 2 hours, the first hour is known as the golden hour. And for me, these 2 hours are platinum hours because these 2 hours tell us a lot about how our patient is and how she's going to behave in the remaining 6 weeks of her puerperium. Next slide, please. We'll go on to the next slide. This is about the active treatment. The next slide is going to, So if there is true PPH, remember, we have to take care of the 4 T's. So to take care of the first T, which is tone, uterine massage. Next slide. So this is how a uterine massage is given. It's a bimanual kind of a thing. So one hand is inside and one hand is outside over the maternal abdomen. And between our 2 hands, one in and one out, we are trying to massage the upper segment or the corpus of the uterus. And we are also trying to maintain the angle of anteversion and anteflexion. Next slide. Second component is to use agents to build up and to maintain the tone of the uterus. So the agents used are time-tested agents, oxytocin, ergot alkaloids, and prostaglandins. Oxytocin is, I think, it has been in obstetrics for many, many years now. Ergot alkaloids have got their own place and they come with their own set of contraindications. And next slide. Something which is very, very widely used these days is prostaglandins. Carboprost used to be used, but now the new chip is misoprostol. It's a prostaglandin E1, and I simply love the drug for the ease that the drug gives me when it comes to dosage, when it comes to storage, and when it comes to administration. I feel even my ward boy can insert a per rectal misoprostol. And I feel it's a wonderful molecule which is now available to each one of us. Next slide, please. So we finished with tone and the next T is trauma. So if there are lacerations and if there are hematomas, we all know already. I mean, there is I know each one of us knows how to close these lacerations and how to deal with the hematomas. And if there is a uterine rupture, that has to be corrected. If it's a uterine inversion, it has to be corrected. At this point, there is one thing which I would like to emphasize. Uterine inversion is a very rare thing. So generally, when you think of trauma, it is not something which comes to your mind very easily. So the beauty is instant diagnosis and instant repair if there is a uterine inversion. Next slide, please. So this is how you deal with an inversion. The entire thing has come out. So we catch hold of the fundus and gently deposit it inside and maintain the deposition inside and combine it with a good uterotonic so that the uterine myometrium immediately contracts and retracts and the uterus maintains its normal position inside. Next slide, please. Then regarding tissue, as I told you, a thorough examination of the placenta. And somehow, if your placental examination is not telling you anything much and you've ruled out everything else, then a good ultrasound also lets you know whether anything is left inside which needs to be emptied. Next slide, please. And thrombin. Coagulation disorders are a rare cause of postpartum hemorrhage and are unlikely to respond to the measures described above. Now, if everyone remembers, I had said that thrombin constitutes for 1% of the various etiologies of postpartum hemorrhage. And why this 1% is extremely important this is the reason. Because whatever measures you may carry on, these measures are not going to help if it's a coagulopathy which is causing the disorder. Generally, coagulopathies are identified before delivery, allowing for advanced planning and preventing postpartum hemorrhage. But unfortunately, if you are faced in your emergency room with a patient with PPH who comes to you pulseless, BP-less, and you're trying every measure to help her out, but it's not helping, remember, one of the important subsets is an underlying coagulopathy, which has never been evaluated and diagnosed. Next slide, please. Now coming on to surgical management of the postpartum hemorrhage. In surgical management, we have the first on the list is transvaginal uterine packing. And there are so many things which can be used for packing. It could be a gauze, it could be a roller pack, it could be a condom pack. Next slide. And then we have these lovely balloons. We have the SB tube. We have the Bakri balloon, which are used for compression of the bleeding surfaces, compression of the uterine surface, compression of the cervical surface. Next slide, please. Next slide. Yeah. Then this is how the vascularity of the uterus and the adnexa is. And so these different measures, ligation of the various vessels to bring down the bleeding, uterine, ovarian, vaginal, and internal iliac ligation. Next slide. And then another important thing which is very much in vogue is angiographic arterial embolization or uterine artery embolization using gel foams. This also works wonders if you're working in a setup where this facility is available, where vascular intervention of radiology is available. I think we should just go for it. It works wonders. Next slide, please. And then we had these time-tested compression sutures, as we call them. Beelan suture, which was described in 1997. Next slide. Heyman suture, which was described in 2002. Plus, we have many other sutures like the Pereira suture, the Cho sutures. We at Vadia, I personally at Vadia generally use the box kind of sutures. I have used Beelan sutures, but I'm more comfortable using the box sutures. Next slide, please. And if all our surgical interventions fail, then the life-saving measure, the gold standard, finally remains hysterectomy. It's a surgical operation to remove that part of the uterus wherein nothing else is helping us to save the life of the woman. Next slide. Yeah. So generally, we go in for the subtotal hysterectomy. Yeah. Next slide. So that's what a subtotal hysterectomy looks like. You have a small cervical stump left behind. Next slide. Well, this is not applicable here. Next slide. And once a lady faces PPH, then what are the complications that may happen? Blood loss, which causes septicemia, hypotension, anemia, fatigue, and finally shock and death. Next slide. So to conclude, friends, in the background or in the light of this slide, there are certain things which I would like to say. Postpartum hemorrhage is around 3 to 6% of all the deliveries happening. And out of these 3 to 6% of postpartum hemorrhage, the traumatic is due to 6 to 15%. Now, what happens in postpartum hemorrhage is, physiologically, there is a lot of increase in the circulating blood volume. So a woman in labor is able to tolerate large amounts of blood losses. And by the time she decompensates, it's quite late. So there is late recognition. Another important thing which I would like to stress is that the diagnosis of PPH is very obvious, but something that is not obvious and that really needs to be hunted for is the etiology of PPH in that particular woman and the extent of blood loss. Next slide. As I said, this golden hour is extremely important. First 60 minutes after the start of PPH, the greater the delay in starting resuscitation, the lower will be the percentage of survivors. This may not be true in trauma because trauma can be repaired, but it could be too late in atonic PPH. So the golden hour is extremely important and we should not miss out on it. Next slide. And the key in the management of PPH is assess, arrest, and simultaneously replace. Next slide. So these are the WHO recommendations. Uterotonics play a central role in treatment. Uterine massage is advised. Initial IV fluids of choice are crystalloids. Tranexamic acid is definitely used in refractory traumatic bleeding. Intrauterine balloon in refractory bleeding when uterotonics are not available. Bimanual uterine compression, external aortic compression. Use of pneumatic anti-shock garments. I mean, these garments are absolutely fantastic because they are available in many of the rural health centers, and these garments buy us a lot of time in transporting the woman from a peripheral hospital to a central hospital. If nothing helps, then uterine embolization, and if that also is not helping, then it is finally a hysterectomy. And as I had told you, I'm going to discuss an overview of PPH with Pooja's Tadka. Now, Pooja's Tadka is not on the PPT. I'm going to speak it out. What I feel is, as somebody who has been practicing obstetrics for the past 16 years, and I'm working in a teaching hospital wherein I have a team of residents under me. So whenever there is PPH, for PPH, every action has to be quick. It has to be simultaneously. It has to be organized. It has to be done in a place where there is good exposure. I mean, you should be clearly seeing what is happening. If you feel that the labor room exposure is not good, shift her to the operation theater. It has to be a teamwork. You should ask for help. If your entire team is with you, ask for more help. Okay, and a good anesthetist also has to be there as a backup. A good physician has to be available as a backup, because finally it's a teamwork and it's a multidisciplinary approach. And I cannot help but stress the importance of parallel counseling of the relatives as to what is going on, because many a times it so happens that so many things we are doing, but the patient's relatives are waiting outside and they are saying, doctor, we do not know what is happening inside. So we have to delegate. As I told you, it has to be organized. So you delegate one person, and that one person will keep on communicating with the relatives as to what happened in the labor room, when did we shift the patient to the theater, now what is happening, what is the improvement, what is the worsening. So if there is improvement, the patient and the relatives understand how the doctor's team has worked. And unfortunately, if there is a mishap, God forbid, but if we end up losing the patient, then it is a process. It is a stepwise process wherein we slowly can break the news. I mean, it shouldn't happen that at one point of time the patient was alive and suddenly you have to go and tell the relatives that you have lost the patient. Next slide, please. Because friends, at the end of the day, every one of us wants to see a healthy mother with a healthy baby. Next slide. And definitely not only a baby which has lost its mother and will keep on longing for mom's love all its life. Next slide. Symbols of love and monuments of love have to be built, but the reason has to be love and not PPH. For people who do not know, this wonder of the world, Taj Mahal, is nothing but the tomb of Arjumand Banu Begum, a 38-year-old para 14, living 14, who died due to PPH at the time of birth of her daughter Gauhar after 30 hours of prolonged labor. So if symbols of love are being built, let love be the only reason and definitely not a PPH. Next slide. As I already told you, the moment a child is born, the mother is also born. Next slide. We at Foxy definitely know that mother's safety is first and everyone's safety is first, and it's our priority. Next slide. This is a big thank you from me to each one of you. I especially want to thank the ISOPARP Kolkata chapter, and lots of thanks to Dr. Bishwajit Guha and to Session sir. They have been tremendous help, and it was lovely sharing the platform with the faculty, and it was an amazing event. Thank you so much.
Thank you, Dr. Pooja, for your very kind, for your very nice presentation. It was an excellent one, and we were all very eagerly hearing to your presentation. I will now. We had a little request, but I think we are running short of time, so we'll leave the Ganesh Bandhana for the next time. It would be nice to hear your voice next time again.
Sure.
So let the session. Shall we now end the session? And I would like to thank Professor Arup Majhi, Dr. Sudeep Chakraborty, Dr. Pooja Bandekar, Dr. Sita, Dr. Tulika, and also our the TOG and Bharat Serum Vaccines for kindly allowing giving us the platform and making this presentation. I can tell you that we have about more than 100 speakers, 100 audience throughout India. And thank you very much. Now I'll hand over to the President, Dr. Arup Majhi, to conclude this session.
Thank you, Dr. Bishwajit, for conducting so beautiful session. And thank you, Dr. Pooja, for covering all the aspects of the PPH. She has actually covered. And two things she has in their original speech, she has not told. That is on the tranexamic acid as WHO's recommendation recently 2017. And another is important thing is the life-saving measure, the external IoT compression. It is not so popular, but I can assure you, if you apply the external IoT compression, especially if the patient is thin, it will be very the life-saving measure. So thank you all. Thank you, Pooja. Thank you, Sudipda, for coming into this. Pooja, next time we'll meet again and we'll enjoy another thing. We lack of time, just 6:30, another scientific ICG meeting today. Thank you all.
Thank you very much. Thank you. Bye bye. Take care. Bye. Bye, everybody.